for out-of-hospital cardiac arrest. So if something happened in your hospital, you're right there, someone has noticed something went wrong, you're going to have a much better outcome. But if it's out of hospital, no pulse rate, no heart rate, no breathing, even in children and infants, it's less than 10%. So that is where EMS comes in. And I think Eric is going to talk to us about how to improve EMS services in Bangladesh on the 20th. Again, children, again, I talk about us meaning pediatricians. We are lucky because kids in general are healthier, number one. And number two, the most common reason for children to have an arrest is for respiratory arrest. And if you properly treat respiratory arrest, you're going to have a very good outcome. But if you have a cardiopulmonary arrest, it's not going to be good. These are the common reasons. In children, it's usually under a year, it's SIDS. In other words, we don't know. Injuries, a fifth of them. And this is something that we don't talk about enough, the third line. In high school aged children, like teenagers, you hear about it. They're playing sports, they're playing football, soccer, cricket, and suddenly they drop dead. What happened? Why did a normal, anyone who's playing sports is usually very healthy. That's what we know. Why did they drop dead? Most of the time, it's because they had an arrhythmia. And they don't have any known pre-existing condition. And it's not easy to detect, but they fall down, they have no pulse, no breathing. When that happens, it's an arrhythmia, most probably a VTAC, VFib. And how do you treat VTAC and VFib? What's the treatment? Defibrillation. You can give as much mouth to mouth, you can give as much chest compression. You need a defibrillation. That's where an EAED, automatic external defibrillator, makes a difference. So if you have one, you should use it. If you don't have one, maybe you should recommend to the hospital that maybe we should get one to keep one in a central area. So the rhythm. So we always worry about child is coming in, cardiopulmonary failure, cortical arrest, and we as providers, we feel very tense that something is coming. How do we manage that? If you can remember this thing, the initial rhythm in a person with cardiopulmonary arrest is asystole, flatline. Second one is pulseless electrical activity. You know what pulseless electrical activity means? Just tell me. No pulse, but some activity. Exactly what it says. Pulseless, but some electrical activity. In other words, asystole. So if you combine these two, more than 90% have no rhythm and the management is the same. So you don't have to worry about how do I manage this, how do I manage this. Almost all of them will have the initial same management. So if you know how to manage asystole, you can deal with 90% of your cardiopulmonary arrest. So just learn how to manage asystole. Pulseless, we always think about ventricular, any ventricular event as being an adult rhythm, and which is true. Most of the cardiac arrest in adults is VTAC, VFib. But we've seen that about 25% of the initial rhythm, and remember what I talked about, the high school student, 1 in 100,000, that falls into this. So a quarter of them will have a ventricular rhythm. So if you have to learn, Sherlina is going to talk about all the different rhythms and the management. If you can just learn two rhythms, asystole PA and VTAC, you can deal with pretty much any pediatric cardiac event. Okay, so like any assessment, you start off with evaluation. And as I said before, we're doing an emergency evaluation. We don't have luxury of time. We have to have 30 seconds to make a difference. So we have to do a primary assessment. And I'll go over the steps of primary assessment, and you won't miss anything, yet you will do a complete assessment, and that too within a minute. And then after the primary assessment, you identify what the problem is. Okay. It could be, we are used to, as clinicians, we're used to making a diagnosis. Is this asthma? Is this pneumonia? That's how we are trained. But we don't have that luxury of time. So we have to make a quick assessment. If you talk about most common reasons, what are the common reasons that you see with respiratory problems, with distress? Pneumonia. What else? Asthma. Croup, bronchiolitis. Those are diagnoses. But what is the primary event going on? Respiratory. So just think about them as a group of respiratory events. And then we can manage a respiratory failure. Same thing, cardiac, different reasons. Myocarditis, arrhythmia, so many different reasons why you'll have a cardiac arrhythmia. But in the end, they're all a cardiac failure. So manage cardiac failure. If you think about that, if they combine both of them, you have cardiopulmonary failure, and if there's nothing working, it's an arrest. So we've evaluated, we've identified what the problem is, and then we have to make a decision. What do we do next? Again, if we have a plan in action, it'll be easier to manage what's going on. And then go back and do a secondary assessment, and that we'll talk about quickly also. So as I just said, many different reasons for each of the events, but as a PALS provider, think about it in this way. There might be different conditions, but they all fall into these three categories. Why? Because that's how we're going to manage them. Respiratory distress or failure, compensated shock, decompensated shock, sudden arrest. You have to recognize early signs. We all know when someone is pulseless. But if they are going into that stage, that's where we make the difference. Because if you miss this, they're all definitely going into cardiopulmonary failure. And if you miss that also, they're going to go into cardiac arrest. So why is that important? The lower down you are, the worse the survival rate. So cardiac arrest is worse than cardiopulmonary failure, that's worse than this. So if we can recognize the problems in the first line, they'll prevent it from going down the line. So how do we do an assessment? Just think of the three sides of a triangle. What are the three sides? And you do that routinely. You walk into a room, you see a patient, and you already made an appearance. How does the patient? Bachar condition, khubi khara. And you've been trained over the years of doing it. That you know which kid is laughing is normal and the kid is lethargic, and you know the kid is. So you do that anyway. So the first thing is appearance. So you walk in, you look at the kid, and you make a decision. So that's very quick. You've already made a decision. How do you make an appearance? If you want to think about things that you look for. Activity, movement, good. What else? Function, color, alertness. So you do these all the time. So if they are a little more active, then you can talk to them if they're older, and you can see their response. So these are things that you look at anyway. The next is work of breathing. And the third is circulation. So you do these three sides, your assessment, immediate assessment for PALS is complete. And you should be able to do this within 30 seconds. In other words, do it as quickly as you can. This child, just look at this picture and tell me, is this child in respiratory distress or in shock? And why do you say that? Open mouth, okay. Accessory muscles are very prominent. Position is called the tripod position, optimizing the airway. What else? Color, looks a little pale. Anxious, very good, anxious. I think you've described all the things that you would to find out whether the kid is in respiratory distress. If I were to ask you what pulmonary airway questions would you want information about? In other words, what information do you want from me regarding his respiration? Rate. So what is the breathing rate? Very important. What else? Okay, but immediate, that will help you right now. Abnormal breath sounds, very good. So any crepitus, any rouse, any wheezing, good. So how is the air entry or there's no air entry? So you can count the respiratory rate. What is the rate in 1 minute? Good. And then the color. Or if you have, if it's an inpatient, what's the pulse oximeter? So if you just have these 4 questions answered, your assessment is complete. You don't have to do any further assessment. You can get a very good idea of what his respiratory status is. What about this child? Respiratory or shock? And the reason? Sunken eyes, lethargy, like listless, not responding. A child like you should be crying. What else? Vacant look. Very good. Vacant look. It doesn't have any interaction. So I don't know how good you can see, but there's a lot of mottling of the skin. Color is pale. So this is shock. So I didn't give you any information, and yet you told me this kid has respiratory failure. So it's very easy to make a quick assessment. And again, just like we had 4 questions that you asked me about breathing, what 4 questions would you want to know regarding shock, circulation? Capillary refill time, good. Pulse volume, pulse rate, blood pressure. That's it. Not a ton of information. That's all the information that you need to find out if my computer is back. Okay. So that is shock and respiration. Okay. Going back, so we did an appearance. Very quickly we found out what is wrong, responsive, unresponsive, lethargy. Breathing, so we did one side appearance, second side is breathing. The way I remember it, you might have a different system, is I use this mnemonic, RATE, race, rate, air entry, color, effort. And these are the questions that you asked me. But this is something that I remember, so when I do a re-evaluation, I ask these 4 questions so that I don't miss anything in my re-evaluation. What are they? Rate, air entry, color, effort. What is a normal rate for a child? It's age related. And as you know, that it changes so much that it makes absolutely no sense in trying to remember all the different age related respiratory rates. So instead, what we can do is look at the extremes. Upper limit, lower limit. And it will be different with age group. So if we take a newborn, if the breathing is more than 60, if we know that newborns breathe fast, usually 30 to 40, 50, that's fine. But 60 is too much. So you need to evaluate to find out why is the kid breathing more than 60. It might be the kid is crying, it might be the kid has a fever. As long as you have an explanation, it's okay. If you don't have an explanation, something is wrong. And then if you look at the other extreme, even in an adult, a breathing rate less than 16 is abnormal. Okay, so these are the 2 extremes, and in between you know that a 10-year-old should not be breathing at 15 or at 15. So those are the extremes. So these, if you have to remember 2 numbers, just remember this. 60 and above is abnormal, 16 and below is abnormal. Next is air entry, breath sounds, we talked about it.